continue with the Professor Oliveira. Professor, you can share your screen. Yes, we can see your slide. You can continue.
For me to participate in this international symposium. I'm here in the city of São Paulo. We will share the experience in pain and stereotax center of AC Camargo Cancer Center and Functional Neurosurgery Unit, Hospital dos Servidores Públicos do Estado de São Paulo. Also, think that the percutaneous techniques for the treatment of trigeminal neuralgia that we adopt in our practice is it is important that we define the disease that we try to mitigate with percutaneous techniques. We will adopt the clinical classification of trigeminal neuralgia, typical, secondary, or primary. According to the pain field complaint and the pain territory, trigeminal somatotropy allows choosing therapeutic targets in peripheral nervous ganglia or structures of the central nervous system. Relief procedures in which we preserve the system are called non-ablative. When purposely damaged the peripheral or central nervous system, we are performing an ablative procedure. Three situations are possible: insufficient injury and previous pain remains. The injury in the right amount balanced and analgesia obtained, or too intense injury and worsened pain. Transformation into a typical neuropathic pain with a worse prognosis for control and iatrogenic pain. Start with the procedure performing on peripheral nerves. Anesthetic blocks are useful as diagnostic tests, therapeutic tests, and a simulation prior to the use of a neurolytic agent. They can be done just once or serially, repeatedly. They can be guided by imaging exams or freehand. The most commonly used drugs are lidocaine, bupivacaine, with or without addition of sodium bicarbonate, with or without vasoconstrictor, with or without corticosteroids. When the procedure is ablative, corticosteroid, alcohol, phenol, and meglumine are the most chosen neurolytic agents. Toxin, botulinum toxin may also be beneficial. Function of conversion pulsed or randomized radiofrequency to a peripheral branch of the trigeminal, such as the infraorbital, can be very useful. The results may be more ephemeral impulsed and randomized application through auto uh, complication rate with this form are very low. Mental and mandibular nerves are useful for third division neuralgia. Access to the trigeminal ganglion was described more than a century ago by Hartel with three anatomic points. The first one that defines the insertion site of cannula is a lateral distance from the angle of the mouth between 25 and 30 millimeters. The second is 1 millimeter medial from the center of pupil on the lower edge of the orbit. The third defines a coronal plane 30 millimeters anterior to the tragus. Anesthetic infiltration is performed at the point lateral to the angle of the mouth. After 2 to 5 minutes, depending on the type of anesthetic used, we puncture the skin towards the other two landmarks. After the passage of the hard palate, we may find it difficult to penetrate the foramen. For many years, neurosurgeons around the world were able to perform procedures by assessing the oval hole only with the variable assistance of Hartel points. In effect, some foramina are particularly difficult to puncture. The submental view with slight rotation to the opposite side to the pane allowed direct visualization of foramen and reduce difficulties in identification and puncture. We use this parameter to find the correct localization. Here we see the surgical times with the monitoring of lateral radioscopy and local anesthesia. The puncture of the skin and the index finger palping the inner surface of oral cavity to avoid needle penetration and possible contamination and bleeding. Then, in-depth progression of the cannula to the base of temporalis bone, changing from the profile to the submental vertex view for identification and consequent puncture of the foramen. On the left, we see a direct view of the foramen in lower drawing and above the foramen already puncture with the fine needle. On the right, we see the foramen puncture by thicker cannula. Thicker inside once inside the foramen, how deep the cannula is the question. There is a need for a lateral radiography view. The clival line is a good parameter of depth and safety. The bone offers additional lines polluting the image. The bone offers additional lines polluting the image. In profile, the clivus line fits the posterior aspect of posterior clinoid. The risk increases then the tip of the needle is about 5 millimeters behind the clival line. Neuralgia of the second division of trigeminal deserve extra attention as the fibers are located more caudal and medial than the other fibers. Lateral puncture favors the angle to reach the fibers of the second division that are medially located. When the electrode offers a distal curve, difficulties usually disappear. Chemical neurotomy of the trigeminal ganglia can also be done by percutaneous puncture of the oval hole. We identify the foramen oval. We wait for the cerebral spinal fluid to come out. We place the patient in semi-sitting position with neck and head flexion. We inject the contrast in fractional uh, manner with a liquid of 0.1 milliliters into the trigeminal system. After visualizing the system, we wait for the contrast to drain and then inject the same volume of neurolytic agent. We keep the patient in a same sitting position for 2 hours. Puncture of a foramen with a large cannula allows the passage of an embolectomy catheter into the ganglion. Once in position, we inflate the balloon with contrast for 75 seconds. During this period, the pressure within the ganglion reaches values higher than the blood pressure, which results in ablation due to ischemia. So we performed in under general anesthesia. On the left, identification of the foramen, puncture with the radio frequency electrode in the middle, and with a cannula with the balloon on the right side. Mm. We see a short video with one micro compression of trigeminal. We have complication of percutaneous trigeminal ganglia procedures, early, intraoperative, postoperative, and a smaller list with minor complication. Trigeminal nucleotractomy can make with percutaneous way, a stereotactic percutaneous way. But this kind of procedure has vascular complications, such as bleeding and vasospasm, that do not occur in the open procedure. So we don't do any anymore percutaneous for stereotactic trigeminal nucleotomy. Acupuncture e eletroacupuncture develops progressively shorter periods as time passes. So I don't have experience. And stellate ganglion block is useful for postherpetic trigeminal neuralgia, and it's very important to perform in ambulatorial setting. Mesotherapy with vincristine or similar is similar to chemical dress. It's very interesting. Thank you all for the attention.
I would like to thank for Professor Oliveira. We are out of our time. Most of the questions answered from the lectures, and I want to thank all lecturers. This is a summary of all treatments we listened from the experienced surgeons, and also for the neuroanatomy lectures. I want to give a special thanks to Matthias. And Professor Zilali, do you want to add anything?
Yeah, actually, probably some speakers may answer the questions already answered by written.
Yes.
We can have some time for discussion.
Okay, and I think for radio frequency ablation, what is the best parameters for pulse, radio frequency, and thalamic lesions in trigeminal neuralgia? I think this is for Professor Oliveira.
For radio frequency, we do lesions about 7 and 75 degrees for 30 seconds or 1 minute, and made examination for the sensibility. The patient is under light sedation and made collaboration during the procedure, and during the microcompression is under general anesthesia, and we do the compression about 75 seconds, and if the deformation is good, if and the pressure also is good. If the modification of silhouette of balloon it isn't good, we change the localization. But it's very interesting because we do not do radio frequency for first division. Only second division and third division, because complication of corneal sensibility.
Okay. I have one question to Dr. Matthias and Dr. John Lee. It was said that the recurrence rate after microvascular decompression, either with microscope or endoscope, is very low. But as I know, it's not that much low. Probably in not very experienced hands, it is quite high. What do you think about that? Actually,
So that's an excellent question. And so I went back to Fred Barker's paper. That's that classic 1996 New England Journal paper published by Fred Barker when he was a fellow, kind of observing Peter Janetta. So he came from Mass General. He went to work with Peter Janetta. He opened up all the charts, called all the patients, and Fred's genius at that time was that he knew statistics. He knew how to do an actuarial curve. Now today, so easy. Just put it into computer, 5 seconds, you have the answer. But when you go back to that paper, he specifically says that the definition of recurrence was not any pain. It was only sharp shooting lightning bolt pain. So patients can, so he made his own definition of what is considered recurrence. Now, if you ask patients though, they have all kinds of experiences. And so that has been my experience. Patients will come back, but their pain has changed. It's not always the same sharp lightning bolt again, but now they have, oh, now Dr. Lee, it's on this, it was here, but now it's here, now it's here. And then and so that's number one. So I think you have to be careful because I prepare the patients very carefully. Like this is only, now there are still also, as you know, the patients who come back with the classic trigeminal neuralgia. And that's where it gets more complicated, what procedure to offer next, because in general, you feel, what am I going to do the second time when I go into the surgery? But I agree with you. The treatment of pain is so difficult because definitions are hard to establish.
Yeah.
Who's going to get better is hard to establish. So that's a great question.
what
Dr.
about that? We used to say in the past that the microvascular decompression is better in the younger ages, but in the older patients, you can make RF lesions or rhizotomies.
It's a good question. The
Now,
surgery, the microvascular decompression
you try
is
to
easy.
say the controversy.
Yeah, no, actually, as you know, MVD is easier in the older patient because
Yeah.
the brain is so slack. So
Yeah.
I actually think, but you're right. If I see somebody who looks like my mother and she's like 80 years old, I just say, we're going to do gamma knife or we're going to do radio frequency. I'm not going to rush to surgery. But
Yeah.
Hi, Professor Emmett.
Yes.
Also,
Hi.
I think completely 100% agree with Dr. Lee. But the matter is that we cannot compare everything with everything. It's easier for a high specialized center to do a microvascular decompression with the high quality as Dr. Lee showed, Dr. Matthias showed. But for a young surgeon, for the first 10 years, learning curve, neurosurgeon, even skull-based surgeon, but the first, second, third, it's not easy to compare. And I don't know how much is too much or too less, but in the last revision from European neurologists, 2016, was less than 10%. It's too much. For us, too much. In our revision was 5%. I think it's not too much, but it's difficult to do a comparison. Also, in the European Neurosurgical Society, my young German doctor, he compared but 10 different center. It's not easy to compare 20 hands. So I think it's a very hard work we have to do in this academic work to define of course, the topic, recurrence in trigeminal neuralgia, which center, which surgeon, and which data we are going to review in 2 or 3 bleeding. Doctor Matías, un estudio 2 o 3 triple ciego, no sé. That's all.
And I saw that Dr. John Lee has said in recurrence, if it is his own recurrence, then he's sending the patient to gamma knife or radio frequency lesion. Is it right?
Yeah, so I know what I did with surgery, and I have video recording, and I can see. I doubt there's much that I can decompress more. So it's rare that I do a redo surgery, but so I will send them. But then the problem is, then they might get relief for 2-3 years, and then the pain comes back, and then the third time, if I might have to do a repeat MBD. But I don't do a lot of my own repeat MBDs. But that's maybe they're going to another surgeon and going to some other surgeon. It's possible.
Okay. Yes, Abuzer, we can finish, I think.
I think
Matthias,
Matthias,
yes, please.
Yeah, 1 minute, no more. I completely agree with Professor John Lee and Mauro, and that's why I think that it's very important to record our surgeries, because if we, as Professor John Lee operates 3, 4, or 5 cases every single week, it's important to say, okay, if the patient comes again to the medical consultation with pain, it's important to review the surgery in order to remember if I was able to observe the length or the complete length of the nerve, if the microvascular decompression was easy, etc. It's important to have the surgeries recorded. And I think that at least in our cases, if the pain is present for a long time, it's important to remember that it's a nerve, and when the nerve suffer an injury, in this case a vascular compression injury, for some months this lesion will be an acute lesion. But if the patient have a trigeminal neuralgia during years, like some cases, this patient will have a chronic neuropathy in this nerve. And maybe we can perform a beautiful surgery, beautiful neurovascular decompression, but the nerve is still with this injury in its fibers of the nerve. That's important to keep in mind. If a patient, and that's why I think that's very, very important to be in close relation and in continuing teaching with our neurologists of our department, in order to remember that the diagnosis is with the clinic. If the patient have this classic facial pain, it's important to offer to the patient the real treatment, that is the surgery, and not to give a medical treatment as a first option.
What's your comment on, in the past, I heard that if there is no significant vascular compression, then you can make some injury to the nerve during surgery. Is it still applicable? Are you still doing this similar thing?
Yeah, so when I was with Dr. Janetta, he would never intentionally injure the nerve, but I could see he was very aggressive with moving the nerve and packing it, and all that movement, I think, causes some injury. And then I listened to a talk, but I'm hesitant to do that because I don't want to give anybody anesthesia dolorosa ever. That was just like so terrible. So then I listened to a talk by Kim Burchell, and he described just taking your round knife and just make a linear parallel to the nerve. They call, some Chinese author call it combing the nerve. So now I will do that. If I don't see, like, I'm not convinced that compression is very dramatic, but I know they have classic trigeminal neuralgia, I will do this. I call it neurolysis. And so now I'm coding that in my results to see if that makes a difference in their outcomes. I still have not yet seen that in my data, but that's the way I do it. But maybe we hear from Dr. Seguro, Dr. Baldoncini.
Thank you for clarifying this. Thank you.
I have opinion also. It's very, very rare, maybe less than 1% that there was no compression. Of course, we have to look for in the bottom, in the how could say, sometimes it's necessary to drill the suprametal tuberculum, and the compression is surrounding the trigeminal nerve in the entrance to the Meckel cave. After 1 centimeter removal, bone removal, and sometimes one vein is just behind the nerve, close to the pons, and sometimes innominate vein is crossing, very small, but it's surrounded by arachnoiditis. So it's very rare. However, I do not prefer, never use the combing techniques, because not ever the combing technique and also the neuropraxia, because the consequences is worse than the pain according to the patient. In that case, less than 1%, we prefer to do the radiofrequency, retrogasserian radiofrequency, like a pulsed technique, 45 degrees, 1 minute, and we have a good result. Of course, we need a long-time outcome.
Compression is a great therapeutic option and also a great teaching tool for residents and fellows. As long as the patient is clinically fit, this compression is one of the methods presented that comes closest to treating the cause. Percutaneous methods are also very useful, but must be done with caution, so as not to cause atypical pain. I think that is a very good tool to teach micro neurosurgery.
Okay. I think we can close session, Abuzer.
Yes, we can close, and also we shared our YouTube channel and the Facebook accounts. You can follow us, and also you can watch again these webinars. I want to thank all lecturers and the audience to join us today. Thank you again. We're closing our session.
Thank you, everybody. Goodbye.
Bye.
Goodbye.